This program is brought to you by Emory University.
All right, good morning, everyone. Finally, welcome to Cardiovascular Grand Rounds. I promise in the next 2 weeks we will switch to a two-click system, which will put us live and actually get rid of some of the lag problems we've had with the videos. So we'll get going. Mike Hoskins, all of you know, is assistant professor here in the Division of Cardiology. Mike's one of our very fine clinical electrophysiologists and did his general cardiology and EP training here. Was part of the initial 3 Mike hire that we've now broken and finally hired somebody whose name was not Mike in EP. But Mike is a fantastic clinician, and he's going to talk to us about, I think, really one of the more challenging problems, annoying problems, and certainly for patients, one of the more important problems when they have ICD shocks that are appropriate or inappropriate. So Mike, thanks so much.
Okay, well, thanks, Dr. Taylor, and thanks, everyone, for coming. This is a topic that I think is important because it's often forgot about. And when we talk to patients about putting in defibrillators, we say, you need this defibrillator because you're going to live longer, and it's what the doctor tells you you need to have. But the patient really wonders a whole different other set of questions. Will this thing shock me? What's it going to feel like? Is that going to harm me? Is it going to kill me? And so we're going to try to answer some of those questions for the patients and talk about ways we can prevent them from getting shocked. These are my disclosures. And so we're going to talk about the frequency and the impact that defibrillator shocks have, and understand how basic ICD programming works and how we can influence that to affect whether or not a patient gets shocked, and then talk about some medical and ablation therapies to reduce ICD shocks. So you would ask, well, really, how big of a deal is this? The patient gets a defibrillator, it's going to help them, and you can see from this guy here who is in need of a life coach that none of us would want to do this to ourselves. And so we should think consciously of how we can avoid this happening to our patients. So let's go over a brief case to start. This is a 67-year-old lady with non-ischemic cardiomyopathy who has an LVAD. She's had multiple episodes of VT in the past, was previously treated with amiodarone for many years, and for the past 5 years has been on Ticasin. She's not certain why she was switched to Ticasin, but she doesn't recall having problems with amiodarone. And so she was admitted during Snowmageddon this past year for an ICD shock. She got up out of the sofa to watch the snow fall and had an ICD shock. Had no symptoms whatsoever prior to that. So we interrogated her device, and this is the scatter plot that we get when we look at an ICD shock episode. And you can see that she started to have VT right about here, and within 10 seconds the rhythm was treated appropriately and she went back into sinus rhythm. And so this is what her rhythm looked like. This is ventricular fibrillation. She received an appropriate defibrillator shock, and sinus rhythm was restored, so she came to the hospital. All of this happened in under 10 seconds. So just a quick show of hands, what would everyone do at this point with this patient? Would you change her Ticasin to amiodarone? Would you reprogram her defibrillator? Adjust her LVAD somehow? Maybe it's the LVAD causing problems. Consider ablation, or just leave things as is. Anyone want to put her on amiodarone? Reprogram her defibrillator? It's working normally. Would anyone just leave things as is? A couple hands there, okay. So we'll talk about what the right option is as we go forward here. So one thing that's consistently been shown with defibrillators is that they improve mortality. And in the secondary prevention data with the AVID and SIDS trial, there was a clear mortality benefit in those patients. And then in primary prevention, we know that there's a mortality benefit, both with ischemic patients and with non-ischemic patients. This is the MADE-IT data and the SCUD-HEF data. And that 10 to 20% mortality benefit has been consistently shown through multiple large clinical trials. The MADE original data was terminated at 4 years. And several years ago, 8-year data came out from that cohort and showed that the mortality lines on the Kaplan-Meier curves continued to diverge even after the 4-year mark. And the hazard ratio for mortality just in years 5 through 8 was less than 1 in the defibrillator group. So even after 4 years, there's a continued mortality benefit with primary prevention defibrillators. But one thing we started to learn in the AVID trial is that therapies from the ICDs are frequent. And these are numbers in the AVID trial which we would no longer accept today. This is 20-year-old data. And a third of patients had ICD shocks within the first 3 months. And at 1 year, almost 70% of patients were shocked. So that's an unacceptably high number by today's standards. And we started to get a glimpse of this because in the defibrillator group, there were a lot of patients being crossed over into the drug therapy group because of these frequent ICD shocks. This is a paper that came out of our group, and Faisal Merchant did a great job with this. It's due to be published next week, looking at the time course of ICD therapies. So if someone receives an ICD shock, what is the likelihood and what is the risk of them getting shocked in the future? And you can see that there's an initial large increase in shocks in the first few days after receiving one, probably a subset of patients that are at high risk of receiving more shocks. And then that plateaus, but still does increase even out to several years. And if you look at the large clinical trials, the frequency of ICD shocks was relatively high in all of these trials, anywhere from 20 to 30%. And these are the duration of follow-ups for each of these trials. But the other thing that we see is there's a large portion of those therapies were actually inappropriate therapies. So these are clearly not therapies that are going to improve mortality, but just make patients' lives worse. If you look at the data from the MADE-2 trial, the inappropriate therapy was relatively high. This Kaplan-Meier curve shows the likelihood of getting inappropriate shocks, which was almost 15%. And most of those were due to atrial fibrillation and SVT, with a smaller portion due to inappropriate sensing from the device. And those are the main categories of why someone receives inappropriate therapy. The other section of therapy that can occur is appropriate therapy, but not necessarily life-saving therapy. In the SCUD-HEF trial, there were 21% of patients that had appropriate therapy for ventricular fibrillation or ventricular tachycardia, but there was only a 7% absolute reduction in mortality. And this was in a trial, the authors specifically stated that they had conservative programming on their defibrillator to try to avoid unnecessary therapy. They turned off ATP, they had one zone, and despite those efforts, there was a relatively high percentage of appropriate therapy despite a modest improvement in mortality. And this finding has been consistently seen in all the main clinical trials that report appropriate therapy rates. That rate is consistently higher than the reduction in mortality. The reason that's so important is because ICD shocks are a big deal for patients. In the AVID trial, patients who had shocks had a negative or a decreased quality of life assessment, and they also felt that their physical well-being was less robust. And in the SIDS trial, patients who had defibrillators actually initially had a better sense of well-being, but that was erased when they got therapy. So anytime patients have a shock or ICD therapy, their quality of life decreases. And this is likely more pronounced in younger patients than older patients, and that makes sense. If someone's 20 and they're receiving shocks in their defibrillator, that really has a big impact on how they feel about their well-being as a young person. But one of the interesting paradoxes in defibrillator therapy is that ICD shocks are actually associated with an increased mortality. And that initially doesn't make a lot of sense. Here you have a therapy that has been shown to reduce mortality in clinical trials, but when someone receives therapy from that device, they actually do worse. And it's possible that that's a marker of worse disease for those patients. But in patients who receive a single shock or multiple shocks, And whether they're appropriate or inappropriate, those patients all have worse outcomes. Here's pooled data that shows several large trials that assessed mortality effect of defibrillator shocks and whether that shock was appropriate or inappropriate. That's been a consistent finding through all these trials, that those patients have an increased mortality. The type of rhythm treated also may impact how their mortality is affected. So if someone has therapy for ventricular tachycardia, it's less impactful than if they have therapy for VFib. And that may be because VFib is a marker for worse cardiomyopathy or worse disease. But it also is associated with an increased risk of heart failure hospitalization. So people with post-VFib therapy from their device have a high rate of being hospitalized. And really, we need to do a good job of monitoring those patients when they get an ICD shock to be sure that they're not getting into trouble at home. This may be one of the answers as to how you can have defibrillators improve mortality, but when you get treated by a defibrillator, have a higher mortality. And we know that people who have very few shocks have a mortality curve that's very close to those who have no shocks. But when someone starts getting multiple shocks, repeated shocks, those patients tend to do worse. And it may be, and we've all seen this clinically, that when patients get a lot of defibrillator shocks, they have myocardial stunning and they have worsening heart failure. And so it may be that if you get just a couple shocks, your life is saved, but if you get multiple shocks, you're going to end up doing worse. And the impact of these therapies is pretty profound. Here are the hazard ratios in the MADIT data. When you had a defibrillator shock for VT or VFib, you had a threefold increase in your chance of mortality, which is more pronounced in patients having renal dysfunction or not being treated with beta blockers or advanced heart failure symptoms. So this is a pretty potent impact on mortality. And so the question that we have is, if you take two groups of patients and you have a high-risk group of patients that are in a control arm, those patients are going to go on to die. But in that ICD arm, those patients are going to have ICD therapy. And really all you're doing is targeting these high-risk patients, and that's why they have a higher mortality. But I don't think that's the end of the answer. I think there's more to it. But in order to talk about defibrillator programming, I think it's important to have a basic understanding of how these devices work. So when we pull up a defibrillator and we look at the therapies that the patient's going to get when they have a tachycardia, this is one sample screen that you might see. It will tell you that they have therapy for VFib and VT. It will tell you how it's going to calculate whether that rhythm occurs, and it will tell you what the rate cutoff that you've selected for that rhythm to be detected is. And so when a patient goes into a tachycardia, this is the raw data that the device sees. These are electrograms. And these markers down here tells you what the computer in the defibrillator is thinking. And so it has started to count these beats, and it's classified them as a fast heart rhythm. It then declares that the ventricular tachycardia is sustained once a certain number of those beats has occurred, or when a rate has lasted for a given amount of time. Those are the two primary ways that defibrillators determine that ventricular tachycardia is occurring. One important thing for defibrillators is to not shock something that's not ventricular tachycardia. So when we see an EKG like this, we can look at this and talk about different morphology criteria and have a discussion as to whether or not this is VT or SVT. But by the time I finish that sentence, the defibrillator will have already decided that and treated this patient. And so it has to have very quick and efficient ways to determine whether something is a life-threatening rhythm or not a life-threatening rhythm. And so the other panel that you'll get with a defibrillator is a host of bells and whistles that are designed to determine exactly that. Is this rhythm an SVT or ventricular tachycardia? If you have two leads, it's relatively easy for the device. This is a dual chamber defibrillator, and this channel is the atrial lead. This channel is the ventricular lead. And that's a pretty easy one for the device. It can say that there's more ventricular events than atrial events, and that's clearly ventricular tachycardia, and it will treat that rhythm. But when you have a single lead, it becomes more challenging for the device. And most defibrillators implanted now for primary prevention are single lead devices. So these are the three basic ways that a defibrillator can tell whether something is SVT or VT. And we call them onset, stability, and morphology analysis. And so sudden onset refers to how rapidly the rhythm goes from a slower rhythm to a fast rhythm. So here is someone with sinus tachycardia, and you can see by these intervals that this rhythm is slowly getting faster, and that's normal for sinus tachycardia. However, if they go into ventricular tachycardia, it's usually a sudden onset rhythm. And so this is very useful to determine whether someone's tachycardia is due to sinus rates going up or a sudden ventricular arrhythmia. Stability is used typically to differentiate between atrial fibrillation and ventricular tachycardia. And so here you have a rhythm that has some long intervals and some short intervals, and that's characteristic of atrial fibrillation. Even though the rate may be fast, the regularity is very irregular. Whereas ventricular tachycardia, all the intervals are pretty close to the same. And for sustained monomorphic ventricular tachycardia, that's typically a very stable rhythm with very similar intervals. And then the third useful tool is called morphology analysis. And this uses the actual defibrillator can coupled with some other part of the wire to serve as kind of a poor man's EKG lead. And so it can make a template of what that person's rhythm looks like during sinus rhythm. And then when they have an arrhythmia, they'll compare the morphology of that beat to this. If it matches up, it will classify it as SVT. If it's different, then it will classify it as VT. And so these are the three primary ways that single-chamber defibrillators can differentiate whether a fast rhythm is supraventricular or ventricular in origin. This slide didn't come through very well, but once it has determined that ventricular tachycardia is occurring, it will typically deliver a burst of antitachycardia pacing. So it will pace slightly faster than the rhythm while the device is charging. That does not delay therapy. And then once it's charged, it takes a quick peek back at the rhythm to say, is this still happening or has it terminated while I was charging? And then it will deliver a shock. So ICD therapies can be proarrhythmic. They're not always life-saving. So here's a patient who, this is within the past week or two, this is one of Dr. Laskar's patients, who went into ventricular tachycardia. The device correctly recognized it and treated it with anti-tachycardia pacing here. And that actually accelerated the rhythm into ventricular fibrillation. It then needs to redetect because now the rhythm is faster and is in a different zone. And so the ventricular fibrillation is ongoing, and finally he gets a shock. And if you can see the time markers down here, they're very small, but this is 35 seconds after the rhythm started. If this were to have just shocked the patient initially, it may have terminated that right away. But therapy in this case was delayed for 35 seconds. Here's another example of proarrhythmia from defibrillator therapy. This is also just a few weeks ago, a patient with ventricular tachycardia that was shocked by the defibrillator, and this is the maximum output of this particular device. And it actually induced ventricular fibrillation. And so fortunately for this patient, he was rescued by a subsequent shock. But shocks in and of themselves are not always safe events. This is an example that was published in Heart Rhythm a few years ago of a patient in sinus rhythm who was experiencing electrical noise on the ventricular lead and got an inappropriate ICD shock that induced actual true ventricular fibrillation. And this patient was at home, collapsed, and it was 15 minutes before EMS arrived and shocked the patient back into sinus rhythm, and at that point the patient did not survive. So if this patient did not have a defibrillator, they would probably be alive at that point. So if you look at the way devices are programmed out of the box, and unfortunately for us, a lot of these devices are put in and no one ever thinks twice about the programming. That patient's got their defibrillator, they're all set, they're safe, but it's really important to pay attention to how you program the device. So these are out-of-the-box settings for Boston Scientific and Medtronic, just to use them as examples. Boston Scientific has 160 beats per minute VT zone and a 200 beats per minute VFib zone. They take 2.5 seconds to detect VT and a second to detect VFib. So relatively quick detections. Medtronic does similar settings, 167 and 188. They use a beat-to-beat count to determine whether the patient's in arrhythmia. And the times here, when someone's in VFib, it does not take long to get 24 beats, so it's within a couple seconds. These are out-of-the-box settings. The reason that's important, if you go back to Faisal Merchant's patient, if you just look at how many zones a patient has, that actually impacts the likelihood of the patient getting a shock. So the more zones the patient has programmed, the higher the likelihood of them receiving therapy. Some of that's because they may have been programmed that way for a reason, but some of it may be not. There was a trial called the Pain-Free trial that came out about 10 years ago. This was sponsored by Medtronic. And what they were interested in is looking at very fast rhythms and could we treat them in a way that did not require ICD shocks. So if you look at this histogram of tachycardia episodes, you get the sense that there's really two populations of tachycardias. These are very fast rhythms, short cycle lengths, and these are slower rhythms. But even within this group of slower rhythms, there's a section of the white bars that are probably still ventricular tachycardia, even though they may fall in the, quote, VFib zone for the device. And the authors of this paper felt that if they could program ATP for this type of tachycardia, you could prevent getting shocked by the defibrillator. And indeed, they found that roughly 3/4 of the time you could successfully treat these rhythms with just ATP. In cases prior to this, these would all be treated with ICD shocks. And this was associated with a very low rate of syncope. So a very effective and painless way to treat very fast tachycardias. The Proarrhythmic trial took it one step further. And they said if we take the detection intervals, the time needed to say the patient's in arrhythmia and extended those out, and we used high rate cutoffs, and then added all these bells and whistles, could we prevent shocks? And they were comparing it to historical data from 2 previous trials, so it wasn't a randomized controlled trial. But what they found was that if you had these extended intervals and high rate cutoffs, that you could delay the time to first shock, and that was true for appropriate shocks, for true VT and VFib, and also for inappropriate shocks. And they actually found a mortality benefit when they compared it to historical data. The advanced trial was the first randomized trial that looked at this. And all they did was when they put the defibrillator in patients is they said, we're going to wait longer before we give therapy. Instead of doing 18 out of 24 intervals, which is roughly a second, they did 30 out of 40 intervals, which is maybe 2 seconds. And they showed that there was a delay in time to first therapy and inappropriate shocks as well. And both shocks and ATP were delayed in favor of the delayed detection. And this resulted in a decrease in the overall shocks per patient from 30 shocks in the standard programming to 19 shocks in 100 patient years. The MATED RIT trial was another big trial that actually, I think, changed the way that most people program their defibrillators. So they had a conventional arm, which is close to the out-of-the-box settings, which in a lot of centers is the way that the patients are left. And then they had 2 experimental arms. One was a high-rate programming, So they had one zone at 200 beats a minute and delayed it for 2.5 seconds before detection occurred. And then they had delayed therapy. So you had a VT zone at 170 beats a minute, and they had a 60-second detection delay. So that patient had to be in VT for a full minute before it would even register with the device. And the VFib zone was at 250 beats per minute with a 3-second detection delay. That's a long time compared to standard. So these are extraordinarily conservative programming parameters that no one would have ever considered using before this. But what they found was that the conventional therapy compared to the 2 experimental arms had a significant increase in the frequency of shocks, both appropriate and inappropriate. And there was also a mortality benefit. So when you had a high rate therapy zone, 200 beats per minute with 3-second detection intervals, you had mortality benefit over standard programming. So all you had to do was change the way you programmed the defibrillator when you put it in the patient, and you had a mortality benefit in that patient. It had nothing to do with differences between patients. And here are the hazard ratios for all-cause mortality, so it was about a 2-fold increase. So if we prolong detection times and delay therapy and add ATP, we can reduce the frequency of shocks, reduce mortality, and we can do that with a very low incidence of syncope. We're always worried about patients passing out, and patients are worried about passing out. But it turns out that syncope is relatively uncommon, particularly with ventricular tachycardia, if you delay that therapy. So medical therapy to reduce ICD shocks, surprisingly, there's very little data on this. There's really 2 main trials. One is using sotalol, and the use of sotalol versus standard therapy reduced the time to death or delivery of the first appropriate shock. And the other was comparing sotalol to amiodarone. And in the amiodarone arm, they used beta blockers. And the amiodarone arm did reduce the time to first shock. And the shocks per year are here. So if you're just on beta blockers, it's 4 shocks per year, which is an awful lot for patients. Amiodarone reduced that to about a half of a shock per year. The adverse effects are things that we would expect: pulmonary and thyroid dysfunction in the amiodarone group. And symptomatic bradycardia was actually most pronounced in the amiodarone group. So amiodarone reduces shocks, but it does so at the expense of side effects. So ablation is another way that we can reduce ICD therapies, and there's actually been fairly good data for this. There are 2 randomized controlled trials looking at this. One was called the VTAC trial, and this took 107 patients with myocardial infarction, low ejection fraction, anything but normal, and a history of stable VT. And they simply randomized them to getting an ICD alone versus an ICD plus ablation. And what they found is that catheter ablation reduced the chance of receiving ICD therapy. And this was a statistically significant decrease. It was most pronounced, interestingly, in the patients with non-severely depressed ejection fraction. So patients with EF of greater than 30% had most of the benefit. If patients had severely depressed ejection fraction, the benefit was less. And it also reduced hospital admissions for congestive heart failure. So this is not something that we think of doing right away in most patients, but there is fairly good data that it does help. The big criticism of this trial was that only 75% of patients were on beta blockers, and about a third of them were on amiodarone. This trial was done in Europe. There was a US trial, very similar structure, that took 128 patients with prior MI and spontaneous VT and VFib, and again randomized them to either receive a defibrillator versus a defibrillator plus ablation. And these patients, almost all of them were on beta blockers, and none of them were on antiarrhythmics. So this is more of a pure patient population. And again, they showed that the ablation arm had a longer time to first ICD therapy, lower overall rate of ICD therapy, And most of that was driven by a reduction in ICD shocks. There was no survival benefit. There was a retrospective evaluation that looked at survival benefit in patients with defibrillators who got ablation versus no ablation. And there was a reduction in overall death in the ablation arm. So if you received a defibrillator shock and did not get a catheter ablation, your risk of dying, short-term and long-term, was higher. This was in patients with not normal ejection fractions, or less than 50%. It also reduces congestive heart failure exacerbations. So the same trial comparing patients with a defibrillator shock that did not get catheter ablation versus those that did get catheter ablation, the ablation group had a significant reduction in heart failure hospitalizations. And the pooled data is consistent with this. These are the two randomized controlled trials. This was retrospective, and this was an abstract only. It never made it to a manuscript. But the pooled data shows that ablation does reduce the recurrence rate of VT and reduces the total number of shocks, although it has a trend, but is not statistically significant trend towards reduction in death. And then one more emerging therapy that we're still learning about is a sympathetic ganglionectomy. And this has been used historically in patients with long QT syndrome and reduces frequency of arrhythmia and defibrillator shocks in that patient population, and is now being expanded to patients with ischemic disease and non-ischemic. And this can be done percutaneously. Mike Lloyd had a nice case of this within the past several months that was done at the bedside. It can also be done surgically, and so we're still learning a lot about this. There are no trials that have shown that it reduces ICD therapies, but it certainly is interesting. So to summarize, we know that ICDs improve mortality. We've seen that consistently in multiple trials, but unfortunately there remains this very high rate of ICD therapies in many patients, and that's associated with worse clinical outcomes. And the strategies that we use to reduce the ICD therapies include medical, device programming, very simple device programming, and ablation. That's it. Any questions?
Thanks, Mike. That's really good. It's definitely a vexing problem for all of us. I have two questions. One, what's the right answer to your question at the beginning? What would you do to that patient? And then two is with the Made It that came out like 2, 3, or 4 years ago. What is have they changed the programming on the devices? And if not, is it not caught up to it, or what's the story there?
So when Made It came out, it was back in the era of traditional device programming. So most of those patients had a VT zone at 167 beats per minute and a VFib zone at 188 beats per minute. And that's conventional out-of-the-box programming. Most of the trials now have recognized that ICD shocks are harmful, inherently harmful. And so the programming has become more conservative. But the time that those primary prevention trials came out, that wasn't really well recognized. The other question for the case was, what we did was simply prolong the patient's detection intervals. Particularly in an LVAD patient who is often asymptomatic for non-sustained arrhythmias, you're doing that patient a disservice to shock them right away. And it's worth giving that arrhythmia a chance to terminate on its own, rather than detecting and shocking all in under 10 seconds in a patient who's completely asymptomatic.
Mike, very good. Do you have a little more information about the injurious effects of repeated shocks in terms of what has been seen in animal models histologically, or can you expand on that a little bit, please?
Yeah, there's several effects. One is something called electroporation, which is where the cell membranes become dysfunctional, the ion channels become dysfunctional with high energy shocks, and that leads to arrhythmias, it leads to myocardial dysfunction, congestive heart failure. If you look at patients who come in with frequent ICD shocks, and a good example of that is a lead fracture, those patients will often be in congestive heart failure and sometimes cardiogenic shock, when the day before they were doing just fine. But once you receive 10, 20 defibrillator shocks, that patient can get very sick very quickly.
How irreparable are those changes?
Usually they're reversible. They're not permanent changes.
Mike, what about electrical storm? Does that reflect a device malfunction, or is it actually targeting arrhythmias that keep recurring repeatedly?
So electrical storm specifically refers to recurrent arrhythmia. Device malfunction is device malfunction, and they can both result in multiple ICD shocks, but device malfunction is considered a separate entity. Electrical storm is loosely defined by 3 or more ICD therapies or arrhythmias in 24 hours.
They're actually arrhythmias.
Those are true arrhythmias. And that's one cause of recurrent ICD shocks is recurrent arrhythmias. We always think of shocks as, failure of therapy, so the patient gets multiple shocks, but often the shocks are effective, but the arrhythmia recurs immediately.
So has the box been changed? What does somebody coming in, not here, but anywhere, and getting a defibrillator, what is the setting? What's the routine now? Is it different based on this evidence?
It should be. I think that people who pay attention to programming have become more conservative. So we're using single.
But if they just pay attention to the rep, what do they get?
It depends on the it depends on the rep. I think that out there, it's likely that a large portion of the patients are getting out of the box settings, and very little attention, if at all, is paid to what the programming is. It's something that maybe they get asked on the way out the door by the rep. And the out of the box settings are the ones that I showed you.
So the settings, the box has settings that haven't changed. So
That's
the
correct.
manufacturer hasn't bought into this yet.
It has not caught up to, the out-of-the-box settings have not caught up to the clinical data. These trials were sponsored by the device companies, so they know about all this data. But I think there's some concern in the community about not wanting to have patients have a syncopal spell and not wanting to delay therapy. But really we're learning that that's overwhelmed by the mortality benefit in not shocking somebody.
So I think that as we look at patients who have indications, guideline indications for defibrillators who might meet those criteria, we need to understand what the absolute benefit is and what the potential problems that the patients may run into. And, as far as getting into shared decision-making with patients around their therapies, that can be very difficult at times. And also how we discuss with patients who maybe have a shorter period of lifespan, 3 to 5 years, what to do when they're reaching end of life, and what to do with the defibrillator and whether to deactivate that. And that discussion can be very difficult with families sometimes because they'll say, oh, well, you're just going to let them die. So question as to how you approach that when you discuss with patients that they're going to get a device, and what considerations might occur as they reach a point, whether they're dying from a cardiac or non-cardiac problem later on. And then the other issue that I don't think you mentioned very much, but one of the more common reasons that I see for patients with who develop post-traumatic stress syndrome is the patient who has atrial fibrillation and gets shocked 6 times. Often it's a situation where they were in the shower, hot shower, they went into some atrial arrhythmia and got shocked multiple times, and the fear that the fact that they were getting shocked 6 times was that they were going to die immediately because of that it was a fatal arrhythmia.
Yeah, well, those are good points. We get the sense that when someone has an episode like that where they're having 6 or more shocks, that's usually an inappropriate session. Most of those are atrial fibrillation or some lead malfunction or something not life-saving. And that we've all seen patients with anxiety and stress after a series of ICD shocks. It's important to treat that aggressively with anxiolytics and aggressively controlling whatever circumstances led to those shocks. And your other point about reassessing someone's need for a defibrillator and discussing their end-of-life issues is also important. There's an emerging concept of reevaluating someone for whether or not they should have a defibrillator at the time of generator change, because oftentimes a lot of circumstances have changed for that patient compared to when they had the initial device implanted. And if they haven't received any therapy in their first device, their chance of receiving therapy with a subsequent device is very low. In terms of end of life, we've actually submitted a proposal to one of the industry partners about evaluating the profile of ICD shocks in the last 6 months of life, because we think that that's a high cluster of ICD therapies that may be a marker of someone dying, but may actually contribute to their ultimate demise, and certainly decreases the quality of life at a time when we should be focused on comfort rather than getting shocked by their defibrillator.
Mike, the incidence of implants in Western Europe is considerably less than the United States, at least it was. Do their numbers differ in terms of percent of inappropriate shocks, et cetera?
That I don't know. I don't know the answer.
I mean, at one time that their implant rate for primary prevention was not much more than half of what it is in the United States.
Yeah, I don't know the exact answer to that. I think that the rate of inappropriate shocks is going to be a function of the type of patient that's getting the device and careful programming like we talked about, and medical therapy. Antiarrhythmics reduce VT, but they also reduce the incidence of AFib, which is one of the primary drivers for inappropriate therapies. But I don't know the exact answer to that question.
So every device we put in should be programmed after it's put in and should be individualized depending on what the arrhythmia is, correct? I suppose there are a group of patients that Andy may be more familiar with that we put the device in because they have a certain degree of left ventricular dysfunction. Maybe they've never had syncope before, maybe they've never had VT before. And in that group, I suppose that the ICD settings out of the box are the ones that are set with that in mind, guessing what the arrhythmia might be, right?
Well, I'm not sure what the rationale for that would be, but I would argue the opposite. Particularly in MADE, if you had your device implanted for ventricular fibrillation, your chance of having a therapy for ventricular tachycardia was very, very low. And the opposite was true. And so in the primary prevention patients, if you don't have a history of monomorphic VT, your chance of having monomorphic VT as your clinical arrhythmia is low. And so having a VT zone at 167 beats per minute puts that patient at a higher likelihood of getting inappropriate therapy.
So we should have that individualized to that patient.
Yeah, I think that if someone does not have a history of arrhythmia and they're getting their device for primary prevention, using these very conservative high rate cutoffs and long detection intervals are important.
So it's always been interesting to me also that in some people who have defibrillators, when the defibrillator goes off, it really is upsetting. In other people, they hardly know that it goes off. And I suppose that has to do with something between the electrodes, or what do you think that has to do with?
Well, if someone's asleep, they're less likely to feel it. If someone passes out from VFib before their device shocks
Before the
them.
device goes off, yeah.
And then there's probably, interpersonal variation of how they perceive things.
There's, your patient that you showed with the pads on up there reminds me, one time I had this patient that had VTAC just numerous times. We had shocked him at the bedside numerous times, given him whatever sedation required. And finally, I decided to try to talk him into and see if like 5 joules would do the job. And he agreed to it. So we went into VTAC and went in the room. We turned the setting down as far as we could turn it, and we shocked him out of VTAC. And he just about jumped off the bed. So it seems to me that no matter what the energy level you use, it still hurts. If you want to make a patient mad, take them around there and don't sedate them enough and let them remember it. I've had them that remember the shocks vividly. They really get mad at the electrophysiologist when that happens. So that's why good sedation is important with that.
Yeah, we think all shocks are painful, and avoiding the low energy shocks in general is a good idea.
Final point, I would think that it's not all pain, it's the startle. Remember that there was once an atrial defibrillator that delivered very low energy, a mere fraction of what you treat a ventricular rhythm with, and the device failed to be accepted because for atrial fibrillation, there were lots of recurrences and the patients wouldn't tolerate it.
All right. Well, thanks so much, Mike. That was great. Thank you.
The preceding program is copyrighted by Emory University.